onset, although you said you can, I mean, usually adult onset, but that's a relative term. Normal appearing anterior chamber angle. So in other words, there's nothing funky about that angle as I mentioned to you. There are 4 things that, the take-home message, this is 4 things that anybody who's at risk for glaucoma from NPS should be having. Visual field testing, cupping of the optic nerve, and others, images of the optic nerve, pressures being checked, elevated intraocular pressure, that's what IOP stands for, loss of nerve fiber layer, which is one of the newer, more sensitive tests for it. If you only have 1 out of 4 of these findings, you're a glaucoma suspect. Okay? But if you have any more, 2 or more, you're a glaucoma person. You're a glaucoma patient. Period. What are the risk factors? Okay, in general for open-angle glaucoma, the intraocular pressure, obviously. Race tends to be higher in African American populations. Age, remember I told you the older you are. Family history, even though despite it's a complex disease, if there's a family history, there's a great chance that you'll have it. Nearsightedness, especially extreme diabetes, hypertension, and migraine sufferers. So what are the 4 critical things? Pressure, the visual field test, nerve fiber analysis, and the clinical exam and recording of the optic nerve status, the picture of that cup. So this is just showing the Goldman applanation time, which is still the gold standard of pressure checking. Some of you have had the air puff, some of you had the tono pen. They are useful, but definitely for anybody here should be being examined by an ophthalmologist. Not even an ophthalmologist, just myself, but even a glaucoma specialist, okay? And then imaging, looking usually with a lens to look at the optic nerve in 3 dimensions and recording that image. This is a visual, this is an old type or Goldman visual field, but there are different methods of testing the visual field, but it's important to have it done by a glaucoma specialist, okay? And this is the automated one. A lot of you have had this, where rather than having a object move and then you press a button every time you see that, this shines bright spots, okay? There's differences in the parameters and they're important, but this is probably the most common type that a patient will have. And it results in this map, okay, visual field map. Wherever you see dark spots, that means that's where you don't see. And the pattern that we see in glaucoma, we describe it as an arcuate pattern. So it has a curve to it. So when you start seeing these kind of patterns, that's different than to say somebody who's had a stroke, which would have what we call an altitudinal pattern, right? So you're missing the upper half or lower half of vision. That's not glaucoma. And over time, you can see the progression in this patient. And so the ophthalmologist is looking and saying, okay, we're not doing a good job. Remember, all the ophthalmologist can do is control the eye pressure. So the question is, how low do we go before stabilizing? So this is based on, at least in part, on the visual field. The OCT, optical coherence tomogram, that's the nerve fiber analysis. Again, every single patient who is at risk should be having this test. And it's actually the most sensitive test that we have to detect early glaucoma, even before the visual field goes abnormal. Not only does it image the optic nerve live in terms of its cross-section, it actually gives you a cross-section, just like the pathology slides I showed you, but more importantly, it gives you a map of the nerve fiber layer. This is the NFL, okay?
Yeah, this is critical because it is the first thing to go. Here's the right eye, here's the left eye, and that tracing is of this patient, okay, and the black line, and it's well into the green zone, meaning it's in the normal thickness. If it starts getting low, and the yellow, that's caution, red means, you know, that's bad. So we've got a lot of loss of nerve fiber. And here's more detail, and you can link it up with the visual field. So, how often should this be done? 2 to 4 times a year, you should be seeing the ophthalmologist. That's 2 to 4 times initially. If you're stable, probably then it could end up being a couple of times a year. Okay? A couple of times if you have glaucoma. If you're screened and you're absolutely, after 2-3 years, you don't have any evidence of that, then once a year, that's fine. The nerve fiber layer analysis, again, 4 to 12 months. Same thing with the visual field testing. Okay, and during this regular exam, not only do they check the pressure, but they should take a picture of the optic nerve itself. So, what's the estimated time of progression in glaucoma in terms of speed of destruction of the nerves? In untreated glaucoma, as little as 3 years at a pressure of over 30 millimeters is when you get irreversible destruction. So you can see why it's super critical to get tested. Because what you lose, you never get back. Okay? That's why there's a lot of abscess. And of course, at lower pressures, yeah, you have more years before you see the damage, but obviously, everything is geared towards early
Mine was
detection.
over 30 when I was diagnosed.
Yeah, and the higher the pressure,
And
the
I got,
more.
and I had symptoms that I didn't know were symptoms.
Right.
Because
No,
I
it's
had it
a
all
silent
the
one.
time, yeah.
It's we call it the silent killer because you
Yeah.
don't know. Nobody says, hey, you know what? I think I lost another degree of peripheral visual field today.
Yeah.
You don't. All right? It's just slowly over years and years and years and years.
Yeah.
Right? And here's typically, look at this nerve. Okay, same patient. Okay, the nerve, very little cup. I'd say a cup of this ratio, maybe a 0.2 or 0.3 here. But you see here, now it's about 0.4, just about 0.5. And what you're seeing is you're seeing clear whitening, but that cup gets deeper and wider at the same time. And the vessels are displaced more towards the nasal side. So that's as far as screening. How do we treat the glaucoma? It depends on certain guidelines. You have to document the tests, you have to document the findings based on the tests that I mentioned to you. A good clinician targets a pressure. So let's say initially they see you and your pressure is at 18. They'd say, okay, I'm seeing glaucoma's damage. I'm going to shoot for 14. Just let's say, pick a number out of the sky. So he or she does everything they can to get your pressure down to 14 or less. Then they keep testing. And if they find the test is stable, great, we keep it at 14. If they find that there's still some loss, then I'm going to drop it down to 12. So that's how they ratchet their target. They always use this target ideal pressure. So you'll see the glaucoma specialists do. If they're not doing that, seriously consider going to another clinician. Okay? They want to attempt to maintain the pressure at the target level, okay, with the least amount of interventions. If you're on a half a dozen drops and so forth to try to maintain the pressure, they should try to move to the next step, okay, whether it's laser or surgery. Okay? Surgical therapy is preferable to medications when treating young kids for a couple of reasons. One is the compliance. Trying to get I don't know when the last time you tried to get an eye drop in a kid, baby. It's not very, and they're screaming and crying. When they cry, they dilute the medication, so they will try drops, of course, but if they find that it's not getting the result, they'll quickly go ahead to surgery. The target intraocular pressure, as I've indicated, is the level where there's no more progressive damage. It is not an absolute value, and it depends a lot on these factors. And also, don't forget on the patient's tolerance of the medication. Some patients can't tolerate. Okay, so all these things factor in. So monitor the side effects, compliance. Okay, the most important thing for adults is it's a pain to use 2 drops a day for the rest of your life, and sometimes they forget, sometimes they want to forget. So compliance is one of the biggest issues for failure of treating glaucoma. Minimize the side effects and quality of life, and obviously educate and engage the patient. The therapeutic sequence in general for glaucoma, you start with medications. Eye drops, that doesn't hold it. You go on to laser trabeculoplasty. Remember that the angle I mentioned to you? We can use the laser in 2 ways. It used to be that we punch holes in it to try to get the water to drain out faster, because we figured it was clogged. That was a simplistic way, because we know if we do punch holes with the laser, eventually after a year, they scar down and they go back. Now they're using laser in the pulse, very light mode, to stimulate a wider, more permanent opening in that meshwork. Okay, so a good glaucoma doc is going to know these techniques and do it. Okay, and the other thing, and believe me, I'm not offending other specialties, and not because I'm an ophthalmologist. And there's a lot of people that are going to their optometrist to manage glaucoma. That's not necessarily bad. However, there's a tendency, and I'm not using a brush stroke to say that about all optometrists, but there's a tendency among optometrists to hold on to those patients a little longer before proceeding to the next step, which would be laser or surgery. Okay? So you may have a good optometrist who's following as long as he or she's doing all these things and take it. And as I always tell you every year, by all means feel free to contact me if you feel like to look at the test and say, is this being handled right or not? But there is no room for hesitation or delay or foot dragging, because what you lose, you never get back. implants, and then what we call cyclodestructive procedure. If you can't make the water leave the eye fast enough or slow it down, the next step is to start to turn off the pump. And you can do that either medicinally or, at the very extreme cases, destroy portions of the pump, start amputating. This is a list of medications. Okay, I won't bore you to death with it. How do we select which medication? Depends on its efficacy, its side effects, the patient tolerance. Some of these, you swear, are putting battery acid in the eye because they sting like hell, but others are not. The cost is another factor. Compliance is a major factor. Surgical treatment, as I mentioned to you, laser. Filtering surgery is when they make permanent openings using either silicone tubes or other shunts. Implants. One of the biggest problems when if you think about it, if I have high pressure, say, well, why don't I just release it by making a tunnel and just letting, well, that's fine and dandy, it works, but guess what? The eye likes to close holes, like the other parts of the body. So scarring tends to be a big problem. So now they have these big plate, very similar to what you irrigate your lawn with. You know, they have these tubes that go to these plates that have multiple holes. So even if the eye tries to scar down, there's still enough diffusion of the water to allow them to succeed. And then cyclodestructive, as I told you, where you destroy portions of the ciliary body by deep freezing or laser, are also done. This is just to illustrate how laser trabeculoplasty is done using a lens, and the treatments are given for so many clock hours in the mesh short. And these things can be titrated, so you don't have to blast the entire 360 degrees. It depends on the pressure and the patient and so forth. And this is what I mentioned to you about the cyclodestructive procedures, which can turn off the pump if all else fails. And the plates where you can actually put a shunt tube in and permanently stays to lower the pressure. These are the investigative treatments. There's a whole bunch of research being done just in terms of neuroprotective agents for glaucoma. So it is an exciting time, but again, the emphasis is always going to be on trying to prevent this. And finally, as Kevin will like, my favorite city. Anyways, questions, please.
Do you recommend to find out if you are at risk for glaucoma to see a regular eye doctor and ask them, or to go to a specialist first?
No, I think if you go to an ophthalmologist or a good optometrist and you tell them that, you know, NPS is kind of mentioned, and it is obvious, but you say, I have a risk for glaucoma. Well, that should raise the alarm right away. Oh, risk for glaucoma? Boom. Then they should do those 4 tests. And this is going to be available.